Is Bill Adams. Bill's going to talk with us about medical informatics. I can't really think of a more topical.
Neither can I.
Excellent. Whether it's predictive analytics, not only baseball, dashboard metrics, artificial intelligence applications. I mean, it's really kind of the center of everything now. And Bill has really led the charge, and our CTSI has led the charge and been the person who's really brought our CTSI and connected us to the world of health informatics. Dr. Adams is a professor of pediatrics. He directs our BU CTSI Bioinformatics Core and our BU Bioinformatics Core. And he also is the director of the Community Health Informatics Network for the Boston Health Net, and a particular interest in improving the healthcare of urban populations, particularly children, as a professor of pediatrics. It's my pleasure to introduce Dr. Adams.
Thanks so much, and thanks for your willingness to listen to a little bit of informatics talk. I promise I won't get too far in the weeds, and I promise that, well, I hope that each of you will leave with some idea that you can use something that I've talked about to advance health equity. There's just so many opportunities, and we need the community to join us. So I start every talk that I give really with a framing of the group of patients and people that we're trying to take care of. And so we have a unique opportunity within the Boston Health Net, which is this affiliation between Boston Medical Center and our partner federally qualified health centers, to really take a population-based approach to health and healthcare. We also have tremendous amounts of electronic health data now. We go back 20 years. So you all know Boston Medical Center is the largest safety net hospital in New England. And we actually have data from our health centers and VMC going back now for over 20 years. We're all pretty much on Epic now, but in the past, we've used actually other systems as well. And when I think about what the mission of the biomedical informatics core of the CTSI is really to make data available and aggressively protect privacy, to think about clinical and translational data-driven research within a socio-environmental context, which I'm going to tell you more about in a few minutes. In how I think about it, actually, it's really helping clinicians to focus on questions more than coding, to align our data here with the data of other sites all across the country so that we can speak a common language, to connect those data systems within networks so that we can work together to advance translational science and to promote discovery and innovation. And for us, a lot of that is around novel data elements like social drivers data that we collect at BMC, but also software and tools that we develop. And I'm going to tell you a little bit about that today too. And pretty much forever, advancing health equity has been foundational to everything we do in informatics and the larger CTSI as well, I would say. I won't go into super amount of detail here, but we do an awful lot of work on site here at BMC, doing something called ETL, extract, transform, and load. So we take data from a variety of source systems, we process them in a staging area to standardize them and align them with other systems, and then we load them into things called common data models. And so if you haven't heard of them, these common data models are I2B2, OMOP, and PCORNet, and they're standard ways of representing data so that researchers can collaborate and use a common language across the country. And just to quickly give you an idea of the landscape of translational informatics opportunities and resources that we have to offer, there's what I call high-touch informatics, where you can meet with folks from the clinical research data for the CDW for research and expert consultation. There's these common data models that I just described to you, and a whole slew of tools and approaches that we've developed over time to help folks out. And then there's networks. And so we are members of now 4 or 5 networks that have a national focus. And we also contribute data to registries that seek to better understand health and outcomes and health outcomes using electronic health data, predominantly around sickle cell and COVID. But that's my first point around advancing health equity. Just by being represented in these networks and these systems, we are contributing to the research experience of the United States. And so number one is to be present at the table and to have your patients represented in the research that's going on. And we do an awful lot of work within the CTSI to make that happen. We make that data available to local researchers here. We also make it really easy to collaborate across the country. But more recently, our informatics focus has broadened substantially. And we've come to really appreciate this idea that really only 15 to 20% of our health is determined by the healthcare that we receive. Now, if you have a health problem that's being treated by the healthcare that you receive, it's really important. But if we're really going to achieve health equity, we need a broader focus. We need to think beyond the health system to the things that make people healthy or unhealthy. And that's where traditionally called social determinants, we've sort of adopted the HRSA language of social drivers to make it feel less deterministic and more actionable. And what we do here in the CTSI is really start to frame health and the use of health data within this context. So the idea that there are place-based drivers of health, there are social drivers of health and environmental drivers of health, and then individual and family drivers of health. And so how can we bring those all together to organize that data, make it accessible for research, and advance health equity research in that way? And we generally think of this as data models and tools that we work on, education and training, which I would say is probably our biggest challenge right now, is developing a workforce that can actually use these tools. And then research applications, which we work on and promote and share with other sites. And then finally, innovation and tools, which I'm going to be telling you more about in a second. I want to pause here. Shortly, I'm going to be talking a lot about race and how race is associated with health. And we've just tried to be more explicit as we go forward that race and ethnicity are used in our analyses because that's the best we have. But we consider these features to be social constructs that reflect unmeasured factors related to individual and structural racism, racialization, and experiences of discrimination. And at least our research group in pediatrics, and I think more generally across the country, are just trying to be explicit about this as we enter into some of these analyses that I'm about to describe. So the data platform that we've developed we're calling the Data for Equity platform. It brings together all that data that I talked about before to create a 20-year longitudinal data set that includes data from our partner community health centers integrated with Boston Medical Center data. We've spent a lot of time augmenting that with place-based data, so information about the census tract that our patients live in and the features of those places. And then we've also done some really innovative we've developed some innovative approaches to link our patient-level data with national mortality data through Trinetics. So we're able to, in a privacy-preserving way, link identifiers from here with a national repository so that we can look at mortality over a person's lifetime, not just while they're here at BMC. We've adopted the OMOP Common Data Model, which is a widely used model that sort of came out of the FDA and is now a standard for national use. We're committed to sharing our software and code. And the wonderful thing about the OMOP Common Data Model community and the Odyssey community is there's just a tremendous amount of energy and shared expertise. So it's easy to find partners and collaborators within that network to do health services research, comparative effectiveness research, and more machine learning and AI type stuff too. So just simply, the OMOP Common Data Model is here. As you can see here, we've taken the location history, which is where our patients have lived at every time they registered for appointments over the past 10 years or so, and linked that in a geocoded geospatial way to place the features about the places where they live. And we've linked the person table to the mortality indices that we get from Trinetics. So we have developed just a much more nuanced and granular model for health and health outcomes. And as of a year and a half ago, we've started to work a lot more closely with the Health Equity Accelerator at Boston Medical Center, trying to advance their research and education piece and also their commitment to integrating social drivers into the research that happens. And this tool that I'm going to describe to you shortly is developed in collaboration with the Health Equity Accelerator. If you want to learn more about Odyssey and OMOP, you can go here. Tons of great information, tutorials, anything you would need to actually start developing your skills and using this data and the data that we have here. So just for the final section of my talk, I wanted to talk about some innovation that we've been doing here in the informatics group. And that's this software tool that we're developing called the Health Equity Explorer. And the idea behind this tool is, could we create an open source, easy to install and use tool that could support self-service exploration and visualization. At the heart of it is we're trying to make data accessible to what we call ordinary smart people. So not people who need to program SQL or R, but who could interact with data in a rich and meaningful way, in a way that could be spread widely across the country. And that's the idea behind the Explorer. We want to be able to support any computable health outcome. So if you can define an outcome in a common data model, you could plug this into that tool. We want to include a broad range of variables: demographic, social, environmental, and clinical drivers of health. We want people to be able to explore data in multiple formats, so graphs, tables, maps, and we also want to be able to provide some reasonably high-powered statistical analyses within the tool as well. And we want it to be open source, so anyone could use it, and we could spread it across the country. And that's kind of a way of framing translational informatics, where you sort of build locally and try to find ways that you can share your tools with other collaborators. This effort started out as a Tableau application, as a proof of concept, but we just finished 3 weeks ago this 90-day sprint with a company called Absalon in their Data for Good program to co-develop an R Shiny app. So if you know about R, R has components that are very much like Tableau, but that also have this really robust underpinning of R and R analytic packages. So you can bring together visualization and statistical analytics in the background. And so that's the tool that we've built. We're building it around what are commonly referred to as equality measures or computable outcome measures that are broadly supported by CMS and other sites. There's roughly, well, there's thousands of them, but there's 1,000 or 2,000 that are in broad use. So we've created a starter set of 20, but the idea here is that there are really, really well-defined computable health outcomes for a variety of conditions. And they're all really well documented in publicly available CMS-supported reference manuals, so that virtually anyone could build a new outcome measure within this tool if they start with these accepted standard measures. And today I'm going to talk a little bit about blood pressure control, which is the proportion of people with high blood pressure who have a controlled blood pressure, and A1C, diabetes control, which is the proportion of people with diabetes that have a controlled A1C, and the different features. And so our health outcome exploration through the health outcome, through the Health Equity Explorer is shown here. And there are basically 3 components to the tool. There's the outcome visualization itself, there's the advanced analytics tool, and then there's the geospatial visualization component. And the idea here, and you can see on the left, a subset of measures, and that we can offer a whole library of computable health outcomes. And for here, we're choosing control of high blood pressure. But then we can view that health outcome through a variety of predictor variables. Some are demographic, some are social, comorbidities, and more recently, we're starting to actually add disability as well, so that virtually any health outcome can be viewed from one or multiple of these variables. We also are committed to being transparent around missingness. So not all subgroups and populations are equally represented in the data, and we make it really easy to see if there are gaps by subpopulation and whether or not that data is available. And then we offer a variety of filters, so you can filter in and see the special groups that you're interested in. We then offer some really nice univariate analyses. So this is all just through a web browser. You can come in, you can explore individual variables, race, ethnicity, social driver, comorbidity, disability. And then you can do what we are calling self-service logistic regression, where you can drag and drop multiple variables, put them into models, see how they work together, and explore them in different ways. And then finally, we've put in some geospatial components as well. So this is a map of Boston. On the left is the Child Opportunity Index, which is a place-based feature at the census level. On the right is blood pressure control. And then you can layer them on top of each other to see how these two features work together to display the intensity of the interaction and outcome. And so as a tool for folks in Boston, this is great, but we also just last weekend were able to show that we could redirect the Health Equity Explorer to a new database, also in the OMOP Common Data Model at the Odyssey Symposium, which just took place. So IQVIA is a private company that's put together a huge primary care-based anonymized data set. And literally within 8 hours, the developer who's been working with me, Sarah Gassman, could redirect our queries around blood pressure and diabetes control to this secondary data set and generate very similar outputs that we've seen here in BMC. And so what this graph, the interesting thing about the IQVIA data is it covers the whole United States. And so we chose the 5 states with the most blood pressures and the most A1C observations. And you can start to look now at blood pressure control by state. And you can pretty quickly zero in with our graphs. You can compare 2 states to each other. So this compares Texas and New York. You can see for African Americans and white patients, overall, there are pretty substantial differences in blood pressure control. And then within each state, there are trends in those blood pressure control rates as well. And then we were pretty, it was really easy then to look at diabetes control. There, the relationship is different. There are still very large differences between Black and white populations, but not really much of a difference within a state between white patients and Black patients. And there's so much more you could do with this tool in terms of the models and the exploration. The idea is that we can't predetermine what people want to do. And if we can set up a common way for folks to represent data and then to explore that data, we can begin to create a national research framework to start looking at health equity across populations. One of the questions earlier was, well, what are other cities doing around health equity, right? And if we had partners in Chicago using the Health Equity Explorer and their OMOP Common Data Model, we could answer that question in 5 minutes now. And so this idea that if we leverage the network of common data models and create tools that will let us use that data more effectively, we could have some powerful outcomes. Now, powerful productivity, I should say. We should pause and acknowledge what all the other speakers have talked about too, that more measurement is not always what we need. And so this measurement is going to be most effective, I think, when it's leading to action. And the ways that I can think about that are, well, number one, to get other folks to use it. So we want to expand the libraries and the codes that people can use to generate these measures. We think this is a common data agnostic approach. So any data model, not just OMOP, could use this. So it could start to become a way of having a national communication about health equity. We think there's a lot of room for expanded functionality for AI and machine learning components that could be added to this. Directed acyclic graphs would be really easy to add in a drag and drop way. And we want to start thinking about equity, not so much as within a health system, how are Black and white patients experiencing health, but across institutions, because truly equity is about everyone rises up to the highest performing systems, not that all disparities within a system are eliminated. So this type of networking also supports a way of thinking in a much broader way. And then in terms of how to make this impactful, we think there's great value in shining a light on inequity for sure. We think that we can discover bright spots, so areas where things are getting better, that we can go out and learn from and share that experience. So when we start discovering ways to be successful, maybe through the stuff we heard about from the Boston Public Health Commission, maybe from other activities, we can spread that and demonstrate it. We really want to dig in more onto root causes and how can we bring in new data and data sources to highlight the root causes and solutions to that. We think, as we heard earlier too, there's an opportunity to inform policymakers through this data. And we think it could be a great tool to spread innovation from the accelerator or from other sites. So when someone actually does something successful, has a way to describe it and package it, and we go to another CTSA or another site and say, can you measure the same thing and shine a light on that inequity, and then commit to adopting some of the strategies that we've proved work here, it could be a really powerful spread tool as well. So those are some of the ideas. I think this group can think of a lot more. And I'm just a pediatrician and a data guy. So we need people in the community to use these data, to brainstorm on how to use them and how to spread that use so that we can start to make some improvements. Thanks.
Questions for Dr. Adam?
Thank you for explaining it in a way that I could understand. I mean, I appreciate that. It's a great presentation. I was wondering, you presented some results with blood pressure, no? And I would love years ago having the access to hundreds of data from patients, no? But again, what I was thinking is this is information from patients. It means a population that has a medical record. Making a parallel with enhanced database, which is a sampling of the population, which each subject has a weight, in a way you can extrapolate to the community. Is there a plan to extrapolate this data from clinical records to the community? No? Because, for example, when you compare one state, I don't know, you're comparing 3 or 4 hospitals, or at how much that represents the population in Texas, in the community speaking.
Yeah, so it's a great question. And for the IQVIA data in particular, we have really limited data about the source of that data. In our data, though, we have access to a lot more variables that can describe and align and help researchers assess the generalizability of the findings. So when we look for partners that have access to insurance status, to certainly high quality race and ethnicity data and place-based data. So the tool itself is good at summarizing that data, but doesn't do it automatically. I think any research projects that we would do, though, would really work hard to describe the denominator population for whatever outcome we're describing, and to say how representative of the place where those people are coming from is that sample. We know for Boston, depending on the health center and the census tract that you choose, BMC patients represent approximately 30 to 70% of that population have had at least one interaction with BMC. So it's not 100%, and we recognize there are a few other healthcare opportunities in Boston that people go to. But BMC and the health centers do have a fairly unique history that keeps our patients more in the system than out. And eventually, we would like to have claims data too, so we can see what happens outside of our health system. But right now, we don't have that. But it's a really important point. And any finding needs to be tied to the place where the finding comes from, and some description of how representative that is within your data. I totally agree.
Bill, nice talk. You said at the close to the beginning of your talk that one of the biggest issues was training the workforce to be able to do these kinds of things. I'm not quite sure what that meant, but because it was a single sentence that went by fairly quickly. But what's standing in our way of educating that particular workforce? I see you're hooked into the Harari Center on the other campus. I know that they're overwhelmed by the educational needs. We do have some graduate courses in data science that for our own students, our masters and PhDs and MDs. What kind of educational programs do you want? I know that other CTSAs in the city have pretty robust educational programs that are whose modules are public. You could use them. So what's standing in the way?
Yeah, so what I've been saying lately is currently on campus, we have more data than scientists. So I've spent 10 years building all these data systems, and they're relatively underutilized. And it's not just my data systems. I think it's the CDW and other resources around here. And I personally think there's at least 3 different ways that we could elevate the workforce. First of all, we need to find investigators that want to do the type of analyses and build a career on healthcare analytics. And There's a lot of data science opportunity there. There just are very few clinician investigators who want to make their focus clinical informatics.
Or who have time, although I think many of them should be
Right.
doing this. Yeah.
It definitely is about interest and time for sure. I think there's also tremendous opportunities to develop a middle tier, kind of a master's level analytic workforce that can support researchers who can ask the questions. So you don't want to be an informatics person, but you want to be a data-driven researcher. If you can work in the way that we've always worked with biostatisticians, could there be a middle tier of experts that could advise? And then we would need to create that workforce. Some of them are available. They're really hard to find and hire. The best person I ever worked with just left me a month ago, who helped me build this whole system because she's just wonderful and everybody wanted to hire her. So, and then I think below that, there's a whole approach that could be focusing on data literacy, thinking in a data-driven way, really at the med school and early career level. And at least in our renewal, we have some ideas around boot camps, around more collaboration with Hariri, bringing all that, maybe inviting collaborators to come over and share some of their research expertise so that we grow internally through collaborations. But, and I'm sure you have even more ideas than that, but those are a few that I think about that might be helpful for our community.
We do have a data science core. Two of them are genetic. We've got three. We've hired three in the last year. And two of them are genetics people, but one is clinical databases. And she's already, after like 6 months, at 110% FTE. So we probably need to hire another one.
Second one.
The
Yeah.
VA wants us to be hiring people. They want to give us a contract. So we could probably pull this together fairly quickly. And I think that the educational programs and maybe a training grant so that our residents could actually get a PhD during their residency or fellowship. Vipul actually got a PhD in that setting. So I know it's possible. And I know Hollenberg's interested in that. So a training program that would make it financially feasible to do this kind of thing. I'll send you
Yep.
an email.
I'm
We can-
here for you.
okay.
And I hear you're here for us too. So that's great. I just think there's so much we could do. And in the past, there have been big limitations on access to data. So it's been hard to argue that we could give you what you need if you came to work here, but that is just no longer the case. We have so much opportunity.
Thank you for that presentation, Dr. Adams. Such a great tool. I wanted to follow up on your somewhat closing comment, which was in order to move this data into action, you really need to collaborate with community. And I'm wondering if you could share your vision for what that might look like.
Yep. So what I learned from you, thank you very much, is that it is just so valuable to talk with the community, right? So in the process of building the Health Equity Explorer, we met with 2 community advisory boards, every leader at BMC that was involved in engaging with the community, and tried to help them understand what we were trying to do and to make sure that we were doing something that was useful. What we learned from the patient community advisory board was that there still is a fair gap between the thing that we take for granted, like blood pressure control, and something that patients in the community are familiar with. And so we retooled and we decided we would create this tool first, and now think about how to reframe that in a truly community advised way. So to me, one natural thing would be to re-engage the community advisory board and say, okay, we have this tool. What questions do you have? And if you give us a computable question, we will give you an answer in 1 week or something like that, so that we start to provide rapid cycle interaction with community members. I think we could do that same thing in a national network with health services research as well. And then we would begin to think about both national collaborations and patient and community engaged collaborations in a way that use the same underlying infrastructure, but sort of address 2 different strategies for exploring health and equity.
I love that. And the CAB would be more than happy to work with you again. Could you share a little bit, if we have time, about your work with the Boston Public Health Commission and how you're adapting the tool to potentially work with them?
Do we have time? Okay. So also, with help from Rebecca, there is a group of CTSIs within Boston getting together regularly to engage with the Boston Public Health Commission around how we can work together within an informatics community to advance health equity for Boston. There was a 10-year experiment here in Boston called the Boston Health Equity Measurement System that tried to encourage all the health centers to send identifiable patient data to a central place to be processed to track 2 or 3 high priority measures. And after multiple attempts, it's just did not succeed. And so we're trying to promote a more distributed approach where individual data owners use tools like I described today or similar code to create a way that we can collaborate across the city to understand health and equity on a citywide scale using existing translational informatics tools. And so particularly with Catherine Hall, who works with Bisola, there's a really strong interest in using distributed computing for public health within Boston. And I'd say we're still early in those conversations, but they see this as 3.0 for the Boston Health Equity Measurement System. And I think it has a lot of promise personally, because it just meets people where they are and can provide tons of rich information fairly quickly at modest cost. So, and better than anything they've had before. So we're excited to help that happen. Thanks.
Regarding a research question, do you envision these models being used to evaluate undocumented immigrants and access to healthcare in the spirit of health equity and whatnot? Or would you envision this being more specific to specific outcomes of diabetes and so forth, how you've been discussing recently?
Yeah, so when we think about it, we think that any feature about a person could be used to inform the health and the health outcomes for people. So if having that status sets you up at special risk, it would become really easy if it were in the system, which it isn't for obvious reasons. But if that were in the system, it could be used to look at whether that group of people have different health outcomes than folks who are better off or more well-resourced. So the philosophical underpinnings are definitely looking at subpopulations and special populations and how those populations experience health compared to other populations. We often go to race as the most obvious one, but we're really interested in 20 to 30 other features of people who live in Boston and how that influences their health. And immigration, migration would definitely be one major feature if we could use it here. If we could document it in the system, we could use it in the tool for sure. Right now, I can't imagine how I would know that about a person, but if I did, we would absolutely be eager to use it, particularly if it could lead to an actionable positive intervention that would help that group out for sure. Thanks.